Thank you so much, Deborah, for allowing me to come and talk today. It's really an honor for me to be here and let me speak to you about my feelings and my work with educating New Mexican clinicians, New Mexican primary care providers, and now reaching out to the rest of the country in terms of a novel approach to taking care of patients with chronic pain. I finished my neurology residency at UCLA and then went on and did a neurorehabilitation fellowship, and I was lucky enough to be in the era of UCLA as they were developing a lot of their neuroimaging and functional neuroimaging, and so I kind of come with a little bit of that background too, so I'm really interested in seeing what's going on the rest of this conference as it relates to new information related to reflex sympathetic dystrophy and complex regional pain syndrome. I can tell you first and foremost that some of the most amazing stories for me working in the area of neurorehabilitation and chronic pain really have come, patient stories have come from those suffering from reflex sympathetic dystrophy. These are the patients that I remember so well during my residency, during working at the neurorehab unit at UCLA with Bruce Dobkin, and then some of the most compelling stories working with Dr. Koshkin here, who's our interventional, want to raise your hand, Eugene Koshkin, who's one of our interventional pain physicians at the university. So thank you. What I'd like to share with you today is really a novel, but rather simple approach to really getting the word out, educating clinicians all around the state in our rural underserved areas and all around the country in similar rural underserved areas when there's a need for better pain education to the primary care providers and so that they can take care of their patients better. Project ECHO stands for Extension for Community Healthcare Outcomes. And the mission is really to develop a safe and effective way to treat common and complex diseases in rural and underserved areas. It began in 2004 by Dr. Aurora, who's in the Department of Internal Medicine at UNM. He's a gastroenterologist who his career is dedicated towards hepatitis C. And what he noted in 2004 was the growing epidemic, the growing incidence and prevalence of hepatitis C throughout New Mexico. He was seeing more and more patients coming in with with capacity issues into his hepatitis C clinic, wanting to get treated. More and more novel antiviral therapies were coming out, and more patients were wanting to get treated. He also noted that the huge rate of cirrhosis and fulminant hepatitis was growing, especially in the rural underserved areas of the state and in corrections and in the corrections area. It was a huge problem in New Mexico as compared to the other 49 states, 10 times more prevalent than the rate of HIV. And so he wanted to do something about it, and he thought what we need to do is really teach the primary care provider how to take care of the patients in their communities, in their homes. So this 4-point ECHO model, kind of the main things about the Project ECHO, Extension for Community Healthcare Outcome, is it really is a way of video conferencing that teaches education, that teaches primary care providers, nurse practitioners, physician's assistants, psychologists, psychiatrists, many other allied health professionals how to take care of patients in an educational forum. It's case-based learning. This is not traditional telemedicine. We are not seeing the patient on the other side of the other side of the screen. And I'm going to show you with a video in a few minutes. So the main points about the ECHO model, is it uses technology to leverage scarce healthcare resources. The University of New Mexico is not different from many other academic medical centers that are also safety net hospitals, that are also public hospitals. The University of New Mexico is suffering from a huge crisis in terms of access, and it's only going to get worse as the Affordable Care Act, or at least bits and pieces of it, gets rolled out. You know, Don Berwick's triple aim states that, you know, we're going to need to see more patients with less money with better quality. And so this model of being able to teach primary care providers to see patients with better quality because of expertise in a shorter period of time, where we have scarce healthcare resources, this model really helps to kind of carve demand, shape demand, being able to provide kind of just-in-time consultations, and clearly with less money. Many of our patients in New Mexico need to travel 4 to 6 hours to get seen, and sometimes the waiting time to get into various specialty clinics can be months. And so if you can imagine that patients are suffering in pain, need to travel 4 hours, and their pain gets worse, their other medical conditions clearly are not cared for, because we know that the number one reason why patients seek medical attention in the primary care arena, in the urgent care and emergency department, is for pain. Their depression, their anxiety, their other chronic conditions are not treated if pain is not under control. So the disease management model is focused on improving outcomes by reducing variation in processes. During this ECHO clinic, weekly chronic pain clinic that we have, we share best practices constantly. We're talking about the latest research. We're talking about the latest outcomes. We're providing balance in terms of medication management, in terms of providing, showcasing the interdisciplinary approach to chronic pain. And as a matter of fact, our team, our interdisciplinary team, really models to the clinician calling in for a just-in-time consultation. We really model that interdisciplinary approach by having this virtual clinic. We offer case-based learning. That's what we do. It's educational. And we provide cost-free CME credits and CEUs for anyone coming online. The university provides this service. All our information is HIPAA compliant. The patients are de-identified, and there has not been an issue with this type of consultative service. This is a picture of, the big picture shows an Project ECHO clinic in action. The smaller boxes around the borders really represent the various outlying clinics calling in on video. The far left is a Department of Health clinic in Las Cruces, New Mexico, in the southern part of the state. The next picture, second from the left, is a federally qualified healthcare center in Albuquerque, First Choice. The next one is a family residency program in Las Cruces. Las Vegas, New Mexico, not Las Vegas, Nevada. This is a primary care provider calling in. The Pecos in northern New Mexico. Someone calling in from Louisiana, and then another well-known, well to us in the chronic pain circles, a physician assistant who has really become a pain champion in her region. So the beauty of this clinic that we've started in 2009. That I started in 2009, and it's grown to have many facilitators, expert facilitators around the table, is that we've created pain champions in their communities. We have providers that call us every week, and now they're taking referrals from their colleagues. They're teaching their colleagues how to take care of patients with chronic pain. Many of them have come to us for several visits where we've provided mini residency programs, if you will. We hear patients that have chronic headaches. We hear patients that have complex regional pain syndrome. We hear patients with complex failed back surgery syndrome with co-occurring complex medical problems and psychiatric issues as well. So the steps are to train physicians, nurses, pharmacists, and educators. I mentioned that. We conduct these telemedicine clinics in a non-traditional manner, as I mentioned. This is not seeing the patient on the other side of the screen. It's rather teaching the provider. We call these knowledge networks and learning loops, in that we teach the provider how to take care of their patients, to consider multimodalities with patient care, not just medication management, but frequently we're advising them on non-pharmacological therapy, rehabilitation, cognitive behavioral therapies, psychiatric interventions, interventional pain procedures when needed. We collect data and we monitor outcomes centrally. We're constantly assessing how we're doing as a team, how we're increasing the self-efficacy of the provider, how we're changing attitudes, how we're assessing the knowledge that's gained from the primary care providers. Many of our providers have gone on and become diplomats in the American Academy of Pain Management, and we have a close collaboration now with Lenny and Deborah, and we're really grateful for that. Dr. Milligan has come to talk a few times at our clinic, and we're also thankful for her knowledge as well. Our latest journey is in looking at how our pain champions in the rural community are doing with their patients, really measuring outcomes. And Dr. Kitkus mentioned that we really don't have good outcomes data and good tools to measure. And right now there's a big effort across the country, and I'm gratefully involved with this, to determine a kind of a national tool to look at tracking outcomes. And we're doing just that in New Mexico by seeing how our clinic is doing in training providers. I really just want to highlight very quickly the hepatitis C trial that Dr. Aurora that was published in the New England Journal of Medicine in June of this year, just to showcase that outcomes really are significant with this ECHO model. So as the huge epidemic of hepatitis C in New Mexico, Dr. Aurora and his team at UNM weren't able to see all the patients. There was significant insurance issues, significant travel issues. Patients weren't able to get out of their rural communities from the reservation and deep in the southwest part of the state. And so he began teaching how to take care of patients with hepatitis C in an interdisciplinary fashion. He has a psychiatrist on his team, an infectious disease expert, a pharmacist as well. And he began to hear cases from primary care providers of patients who had hepatitis C, both in the rural communities and in corrections. And the outcomes were unbelievable. He heard cases of 261 patients in the rural communities, and he himself and his team at UNM saw 146 patients. So he was able to actually co-manage, if you will, more patients in the rural communities than he saw at UNM. The differences in the minority population were slightly more. There were more underserved patients and minority patients in the rural communities, which is no surprise. But the biggest result here is that depending on the genotype of hepatitis C, there was actually a better cure rate from his teaching rural providers how to take care of hepatitis C than he even had at the University of New Mexico for the genotypes 1 and 4. For genotypes 2 and 3, it was pretty much equivalent. And so basically he was able to train providers who did not have fellowship training in gastroenterology, did not have fellowship training in infectious diseases. He basically taught providers to do significant work and created amazing outcomes. So these are the tele-echo clinics in operation. I highlighted some of them, some of kind of the larger clinics. Our clinic is the chronic pain and headache management clinic that meets weekly. Thanks to Dr. Milligan, I'm able to get there today by moving some of the schedule around because we have a clinic today where we're hosting some visitors from around the country to to try to replicate this on their own, and so I'm going to run back there. But we meet Thursdays from 12 to 2 and hear cases and have a robust didactic curriculum as well. Dr. Aurora likes to call this idea a force multiplier. I think it's a great term because what we are able to do by teaching one provider, by having one provider, one mid-level provider, one primary care physician become a pain champion in their rural community, they're then able to teach their colleagues, who are then able to teach their colleagues, and patients benefit, and it really spreads extremely quickly. There's a lot of technology associated. It's not too advanced. We use different polycoms for video conferencing. We have webcam interfacing capacity. We're monitoring outcomes on a program called iHealth, and that's what we're working on right now with our chronic pain clinic specifically. We track the providers that call in, the cases they present, where they come from, are these unique sites through a tool called iEcho. We use webinars, and we put all of our clinics up online in terms of our didactic presentations that are available to all of you.
And just click on the image on the screen. There you go.
This is a video of our clinic. Volume.
We might have to go to...
Well, Erin is helping me with this. This is a video we put together. It's a abridged version of a video that really showcases our clinic, because I can talk and talk, but you can't really get a full appreciation unless you really see it in action. This is a video of our clinic, a provider in northern New Mexico, and even a patient who is given a release to have himself videotaped, but you'll kind of get the idea of how this works. Turn it up.
A very complex problem, and it needs to be handled by a group. It takes a family to wear out that old saying, but it really takes a village to take care of chronic pain. And that's what we have here. We have a group of various specialists that can help us see the whole picture.
There is evidence that he's having transient nerve root irritation that is now becoming so severe that it's limiting his function. This is one of those cases where the MRI doesn't really collaborate the clinical picture, but it really helps support the region that's involved, which is the L5 nerve root.
The primary purpose of Project ECHO is something called force multiplier. That is, the goal is to dramatically improve the capacity for providing complex health care in any region.
Espanola is a small community of about 10,000 people. I'm doing well.
How's it going?
Good. How you doing? At our clinic, we serve tiny mountain towns and villages throughout northern New Mexico.
Can I see your other leg?
And this area really doesn't have anything in terms of any kind of formal chronic pain management program.
So my main question about this patient is that...
And I've learned so much. I've benefited so much from the didactics, and it's really been a miracle for my patients.
The first week was 2 times, now it's 3 times.
Okay.
Suboxone and tryptophan injections have really worked.
And I want you to take this leg and just slowly raise it up.
You know, it is constant pain. It's a burning pain. What we're doing now is just taking care of the pain symptoms so I can try to function. So far it's been working.
Just pulling.
And right here. Pulling up.
I really think that we're teaching providers around the state how to better take care of their patients with chronic pain. We're supporting them, we're increasing their knowledge, and they're then teaching their colleagues how to take care of these patients.
So, according to our definition of chronic regional pain, there's 2 types.
Any pain in there?
Of all the things that we take care of as clinicians, probably the taking care of pain is probably the most undertreated problem that we have in the United States. I think the strength of the RECO pain model here is the fact that it's very multidisciplinary. define pain as both a physical and an emotional experience. And so right there, based on just the beginning of that definition, you need a more holistic view. You need a representative from the somatic or the body, the physical side. And you would be remiss if you didn't also take into consideration the psychological, the psychiatric aspect of living with pain, which is a distressing experience.
She is going to come back to the clinic to get labs.
I'm very grateful to Project Echo. I mean, I didn't have this knowledge base before I got it. Patients are losing weight, they're exercising, they're getting referred to specialists, they're getting imaging done, they're finding out what their true diagnoses are, they're taking their lives back. I see that patients' lives have been transformed because of Project Echo.
So our team consists of myself. I'm a neurologist. We have a psychiatrist who's board certified and trained in addictions, Dr. Koshkin from interventional pain, Dr. George Commercy, an internal medicine physician who's now a diplomat in the American Academy of Pain Management. We have several myofascial therapists, and we get specialists all the time who are really gravitating towards ECHO and wanting to be a part of the program, and pharmacists from the College of Pharmacy are coming, and so we provide this interdisciplinary program. There's no cost CMEs and nursing CEUs, as I mentioned. We develop local pain champions. We provide consultation to that provider within a week. So, for instance, they can fax in patient information this morning, and we can hear their case this afternoon on Thursday. If they miss the clinic on Thursday and see a new patient in clinic with pain problems that they're having difficulty with tomorrow, it'll just be 5 days before they can make that presentation to us. Additionally, I make myself available, as most members of our team do, through email and through calling our physician access line at the hospital. So I really talk to many of our providers and get to know them over the phone if they have an important question to talk about before the next clinic. We've eliminated geographic barriers, tremendously cost-saving for patients, and we've created local and regional chronic pain centers of excellence. Many of our federally qualified healthcare centers, we've engaged so much that they've provided a physical therapist, a clinical psychologist, and a psychiatrist on site, so they can they're developing now interdisciplinary pain teams, because we know, as Dr. Kitkus mentioned, that the Institute of Medicine came out that pain in June of this year, that pain really needs to be treated as in an interdisciplinary fashion. And really part of that white paper really was that not only that it should be interdisciplinary in nature, but that it really needs to be treated at the level of the primary care provider, since these patients are seeking primary care first and foremost. The Department of Defense came out with a similar position paper the year before, and we're working closely with the VA hospitals and the Department of Defense now in trying to streamline the ECHO model throughout the military, both with our veterans and with our active military, and trying to create an outcomes tool as well. These are our partners. We have a close partnership with the University of Washington Pain Program, with the VA, as I mentioned, with many of our own federally qualified healthcare centers, with our GME, our Graduate Medical Education Residency Program, and we have many residents and medical students that come through our ECHO program. The New Mexico State Department of Health, as I mentioned, with Lenny and Deborah, and the American Academy of Pain Management, and with our Indian Health Service. This is just there's no way you can see these small colored boxes, but it just represents where we are on the state in terms of chronic pain clinics and the various ECHO clinics that really serve the state. As you know, there's tremendous educational challenges in chronic pain, and part of it is that no single medicine specialty owns chronic pain. Patients are seen in a whole host of specialties. The primary care provider, the neurologist, sees the bulk of the patients with chronic headaches. In terms of back pain, it's really all over the map from the primary care provider, the physiatrist, the orthopedic surgeon, the neurosurgeon, the interventional pain physicians. In terms of fibromyalgia, again, multiple specialties see these patients. Partly this is because no residency training is dedicated to chronic pain, yet there's been a lot of mumbling about a primary pain residency, and my guess is in the next 10 years, I think there will be a primary pain residency. If you really think of chronic pain as a disease entity and encompassing so much of all aspects of care, I think that this is a necessary step in the right direction. And Aaron and Judith Kitkiss and myself worked a couple of years ago on trying to double the number of hours of chronic pain education in the medical school curriculum in all 4 years. We were successful on that, but it's still extremely variable in terms of residency education. We still have a lot of work to do, I think, in medical school education, but residency education is all over the map. Some programs require as much as 1 hour during their 3 or 4 years of training. Others require, rotations. But it's there's so much variability that when residents leave the program, leave their specific program, they have extremely different knowledge base in treating chronic pain. This is an interesting study from 2007, is treating chronic pain torture. This is a no pun intended, right? This is a study out of Brown Medical School looking at, they queried 124 medical students, 110 responded. They wanted to evaluate the confidence in medical students in treating chronic pain, their experience with chronic pain patients, and their attitudes in their outpatient practices in taking care of patients with chronic pain. This is just a nutshell. I have the reference below. But interestingly, but not surprisingly, 63% of the medical students reported feeling somewhat or much less confident in treating chronic pain at the end of their medical student education as opposed to diabetes. Okay? And interestingly, confidence did not increase with their level of training. Okay? It did not get better year after year. I wanted to give you some statistics and just show you kind of this force multiplier effect with our chronic echo program in terms of being able to reach out to primary care providers, nurse practitioners, PAs, clinical psychologists, doctors of oriental medicine, complementary alternative medicine folks, psychologists, in how we're doing as our clinic has grown from January of 2009 to the present. We started in January of 2009. During that year, we had a total attendance of 480 people come on board. These were not unique providers, but 106 of them we had unique attendees during that year at 38 different unique locations. The first year was primarily New Mexico. 2010, we grew to having 134 unique attendees at 42 locations, still mostly in New Mexico, and then pockets of the country where providers were calling in for our support. And then this year, we've had a total attendance of 935 people call in, 191 unique attendees. An average number of attendees per clinic is at now 28 providers calling in per clinic. And if you can imagine 28 providers calling in per clinic, not all these providers are presenting cases. As a matter of fact, we don't have a lot of cases of patients being presented. We might have anywhere from 1 to 6 cases. The rest of the providers on the line on video or audio, if they can't get a webcam or Skype up, is they're hearing cases and they're understanding better how to take care of their patients with reflex sympathetic dystrophy, with complex intractable migraines, with severe back pain associated with perhaps addictions and severe anxiety and depression, and don't have insurance and need to find out other modalities besides pharmacological entities and so on. And so if you can imagine the force multiplier effect of this, it's significant. What I also wanted to share with you is, by far and away, these are not just physicians. These are approximately, what I wanted to show here is year to year, the percentage of years attendance by physician or osteopathic doctor. It averages about 41% of the providers who come online are physicians. The other 60% are a combination of mid-level providers and other allied health professionals. So if you can imagine that chronic pain really needs to be treated in an interdisciplinary fashion, we need to teach the whole gamut of professionals, not just the physician. We need to teach physical therapists, we need to teach clinical psychologists, we need to teach the clinician pharmacists, we need to teach the doctors of Oriental medicine, and so on. And so we get a whole range of clinicians interested. We have a chronic pain curriculum, a year-long chronic pain curriculum that is all archived. Included in this chronic pain curriculum that really has a theme month per month. For instance, we have a theme on fibromyalgia, myofascial, and osteoarthritis. We have a theme on pharmacotherapy, a theme on neuropathic pain disorders, and we have had several talks on reflex sympathetic dystrophy. We also have video myofascial skills demonstrations approximately once a month. For instance, this afternoon we're having a very well-known doctor of chiropractic come down from Taos. She's written many journal articles and written a very well-known publication in the clinical mastery of myofascial pain. She's coming down now once a month to provide myofascial skills demonstration live. So any provider who comes on the video will see her demonstrate how to examine a patient with severe cervicogenic headaches, how to examine them for myofascial pain in the neck and upper back, how to check for referred pain into the abdomen via pain in the low back, things like that. So these are all archived as well. We are also preparing providers to take credentialing exams and have a lot of educational aspects to our program, including journal club topics. We survey every provider during the clinic. They all have felt on a scale of a Likert scale of 1 to 5 that they all have marked 99% of the time that they feel as though the presentations are effective, they will likely use them in the future, and that they have a clinical relevance. We are right now looking at attitudes, knowledge gained, and self-efficacy or confidence in terms of how we're doing by teaching primary care providers about chronic pain. And we're collaborating with a single outcome tool right now with the University of Washington and with the Department of Defense in really looking at chronic pain as a continuum, not just a Likert scale of 0 to 10 in terms of how are you doing in terms of your pain, but how is it affecting your function? Are you able to take care of your child? Are you able to go to the grocery store? Are you able to enjoy life? How is your relationship with others? What's your pain interference score? We're also looking at what is your risk of addictions through various tools. There's various tools out there that you know of, whether it's the opiate risk tool, the Calm, the SOAP. We're looking at that. We're looking at the overlap of depression and anxiety, because we know that that anxiety is probably one of the biggest co-founders in pain not getting resolved quickly, especially as it relates to intractable headaches. So we're looking at various outcomes tools right now. I just wanted to give you an example of another clinic that we have that's very successful, the Integrated Addictions and Psychiatry Clinic. It focuses on all aspects of addictions, not just opiate addictions, but alcohol addictions, smoking addictions, illicit drug addictions. But its main success has been in the focus on treating opiate addictions. And so many times we will, Dr. Kamarnami and myself will refer patients or refer providers back and forth to each clinic. And many providers will actually use the resources of both our clinics. Well, this opiate or Integrated Addictions and Psychiatry Clinic trained and certified 158 physicians. Now, as you know, only physicians can become certified to use buprenorphine, use Suboxone in the country so far, meaning mid-level providers and other allied health professionals clearly cannot prescribe. But they've been able to train 274 clinicians. So mid-level providers have also been able to understand how this is being used. I wanted to show you a really compelling graph in terms of how New Mexico has been doing in certifying buprenorphine providers and getting outreaching and treating opiate addictions in rural New Mexico that has a high proportion of Hispanics, a lot of underserved, low-income patients that can't get into the university and clearly can't access our addictions services. Northern New Mexico has one of the highest prevalence of opiate addictions in the country, primarily heroin addiction in the area of Española. The PA, Debbie Newman, who was on the video, works out of one of the federally qualified healthcare centers in Española, New Mexico, and she sees patients with addictions as well. The head of the Addiction Psychiatry Echo Clinic began training physicians to use buprenorphine via day-long trainings in 2005, and since that time you can see how New Mexico compares. New Mexico is the blue line that has a sharp rise compared to other states. So we've really spread the word and knowledge out on the importance of opiate addiction and the benefits of providing buprenorphine in the patient's medical home, in their medical community.
Addiction to what?
Addiction to opiates.
Opiates?
Yes.
Not alcohol. It doesn't include alcohol and other substances?
No, just opiates.
And these are prescription opiates or?
And any kind, you can treat heroin addiction with buprenorphine as well. Yeah.
No, I was looking at the incidence. The incidence to addiction, is that to just opiates? Prescription opiates?
This doesn't have, this graph, this is not related to incidence. I'm sorry. So the x-axis is date of certification and the y-axis is the number of licensed providers. The line in the middle is when the beginning of the buprenorphine training was initiated through Project ECHO. The blue line represents the number of New Mexico providers certified in buprenorphine compared to other states. So finally, and then I just would like to open it up to question, every year providers who are engaged in the Project ECHO for all the various clinics come together for a very large annual meeting where this past year we surveyed them on some aspects of how they're doing in their communities. The University of New Mexico has taken a big interest in creating accredited patient-centered medical homes, and now we have 9 patient-centered medical homes to offer comprehensive primary care and behavioral health support throughout the university system. And so we wanted to get an idea of how Project ECHO can facilitate patient-centered medical home in provider communities around the state. These are just some really impressive results showing that these providers calling into our various ECHO clinics felt as though Project ECHO improved continuity and coordination of care, enhanced quality, teach valuable concepts about team management, and enhances the ability to offer comprehensive care. Next question was how participating in Project ECHO benefited providers treating patients with chronic diseases. They felt as though Project ECHO helped them learn best practice care, developed clinical expertise, and increased their comfort level or self-efficacy. They also felt as though Project ECHO reduced the provider's costs of care, that they were able to save money. The patient was able to save money by reducing the travel for specialty care and testing, reduced emergency room visits, providing consultation regarding appropriate use of ancillary services and tests, decreasing visits by patients to specialists, and through early intervention. These are just some of the list of awards that ECHO has received. And then just finally, to close, what are the potential benefits to the health system as a whole? It really goes along with what the country's trying to do in terms of Don Berwick's Institute of Healthcare Improvement and Triple Aim in terms of providing quality care at a lower cost and being able to see more patients. It also, we know, we've looked at this, that it improves professional satisfaction, it decreases isolation. Providers want to continue to take care of patients that are difficult and complex because they know that they have the support. It's cost effective, and it really supports the medical home model. We're also doing a big outreach, a big push in terms of being able to, trying to apply lean principles at UNM. And I just had the idea for an article that what really ECHO is ECHO is lean. ECHO is kind of the leanest of the lean in that it really eliminates all waste, all non-value added, and really gets to the crux. So I thank you for your time, and if you are at all interested, the clinicians especially in your group, if you're at all interested in coming online either on video or audio, or perhaps considering replicating such a program in your neck of the woods, in this country or outside of the country. We have programs in India, in South America. Please, perhaps maybe let Erin know, and she can get the word to me if you would like more information. Because we have replication visits 2 to 3 times a month where clinicians from all around the world come and we provide them a couple-day training into how to replicate this in their sites. So thank you. Yes.
For the ECHO Center, how do you cover the cost of physician time in the ECHO group?
That's a great question. It's a question that always comes up. We are supported by state monies, by federal monies, by a very large Robert Wood Johnson grant that has been recurring. And we're actively looking at insurance companies have actually been approaching ECHO because they realize the tremendous benefit to this in terms of them. They actually, Molina, which serves, it's our SCI or Indigent Medicaid, one of the payers, one of the insurance companies that provides Medicaid services to the state, approached ECHO and is now paying providers to come online and present a case. What a concept. I mean, because they realize that if patients get their care treated in a best practices manner, early, so that other problems don't build up, that they're actually going to benefit as a health plan. And so there's active negotiations with several other large insurance companies. But it's pretty much grant supported and state and federally funded right now. So what happens is that the facilitators, at least the medical directors, their time is essentially kind of bought out by, Dr. Aurora will go to my chairman and say, I will, can I use Joanna, 4 hours a week, and I'll pay that portion of her salary. So that's what's happening right now. I think it's going to evolve quickly. We're already seeing a couple of changes to this, and we're, as federal fundings are dropping, there has been some cuts to the program, and we're making up for it in other ways. But yeah.
Thank you for that wonderful presentation. This is actually the tele-echo concept is very impressive. With regards to the types of questions that you're getting, it seems the small proportions were patient-specific, and the rest of it is more general education. And so you may want to touch a little bit as to what kinds of questions you're getting from these providers.
Yes.
And the other is, apart from number of providers and number of patients, what kind of other outcomes you're measuring, such as, changes in pain outcomes or functional outcomes in these patients?
Great questions. Thank you. The first question is, we have actually, the patients that are presented in depth and are presented in a very logical manner. The providers are asked to fill out a 2-page simple template, but does identify the question that the provider is wanting to ask, whether patient has reflex sympathetic dystrophy. We've tried these various neuropathic agents. We sent them to physical therapy. They're still in pain. They perhaps tried a diagnostic sympathetic nerve block unsuccessfully, but tried just once. What do I do next? They have overlapping anxiety and depression. But I'm situated in Chaparral, New Mexico. I don't have resources to a psychologist, a psychiatrist, to a swimming pool, to ongoing physical therapy. What should I do? So they fill out a form that includes medications tried, the reasons why they weren't working for the patient. What are the active medications that the patients are on now? We ask them to fill out what other things they've tried: physical therapy, interventions, massage, other integrative approaches. We ask them to fill out a template on their exam, their neurological exam, and we ask them a series of questions about a substance abuse history and psychological factors. So it's coordinated. Clearly, a provider can come online and just ask a specific question. Just kind of a curbside, if you will. I have a patient with X, Y, or Z. What do I do? But we really honor those providers that have filled out a full template. We also have, every clinic has a 20 to 30-minute didactic session. So for instance, today, Dr. Ferguson is going to talk about pelvic floor muscles, referred pain to the pelvis and the abdomen. Okay, so we have a specific didactic. The clinic starts at 12. At 12:30, we go right into the didactic. So from 12 to 12:30, we hear cases. 12:30 to about 12:50, we have a didactic. We take advantage of the clinician being busy and being able to use this during their lunch hour. They very often will see the meeting in their office or in the clinic online, and we get to know them quite well. In terms of outcomes, we have measured outcomes related to knowledge, attitudes, self-efficacy, and we're in the middle of creating those outcomes tool to be able to study how those providers are taking care of their patients.